Hi, this is Brian Kim. I'm going to share with you case number 150 in the best way to do cataract surgery series. You're going to see some posterior synechiolysis using forceps, as well as confident lens disassembly with double chop, cross chop mechanical fracturing techniques through a corneal scar. The benefit of performing mechanical fracturing and double chop and cross chop is even if you have a suboptimal view, and just like in the situation of a small pupil, you can crush the lens because you're confident of your location of your instruments, and you're able to crush the lens with crushing forces rather than depending upon lollipopping the lens, sculpting the lens, holding the lens with vacuum. And in my opinion, this is just a lot more easy and less risky way of chopping the lens. So that was a corneal marker, which will help me to center incisor-rhexis. I'm making my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then some intracameral epinephrine. And this is some intracameral viscoelastic, dispersive viscoelastic, and it's filling the anterior chamber. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I like the length, I turn the eye towards me with the cannula, and then I enter. So you can see there's posterior synechiae away from me. The field away from me shows that there's a pretty dense corneal scar in that quadrant, as well as some posterior synechiae. So I'm going underneath with the viscoelastic cannula, and I'm trying to separate the posterior synechiae off the anterior lens capsule. And now I'm using a two-handed technique, using two microforceps to grab the pupillary edge because it's quite fibrotic and stiff, and using a two-handed maneuver without putting too much stress on the iris root, I'm able to peel that membrane off the pupil. Now you can see the pupil is a lot bigger and more round. I'm going to use the forceps to puncture the center, pull down, grabbing the tear, and then I'm going to go around circumferentially. Again, you can see I'm using the marker there on that hash marker on the forceps to give me a better idea of the diameter of the rhexis that I want to make. So I'm going around circumferentially. Again, on that side of the eye, you can see the corneal scar. A little bit of harder view there, but I'm able to find the edge of the rhexis and go around. I have excellent control, it's not running out. I finish off the rhexis, rub some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place the cannula out under the rhexis edge contra-incisionally, get a nice wave, decompress on the left side, and then I hook the peripheral lens on the right side and the lens begins to spin. Irrigate the surface of the eye, adjust the sleeve, lift the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. And this is in slow motion. I have the chopper pointed out toward the periphery, go underneath the rhexis edge, contra-incisionally rotating the hand. So now the chopper is straight up and down, but slightly pointed towards me. I'm turning the phaco tip vertically sub-incisionally, stabbing the lens, bringing the instruments together horizontally. I'm able to fracture the lens completely in half. That is the double chop. Again, I place the chopper around the right heminucleus, making sure I get underneath the rhexis edge. Again, rotating my hand again so that the chopper is pointed up and down, pulling it centrally towards the phaco tip and fracturing the lens against the instruments, and that is the cross chop. I lift the first quadrant up with some vacuum and then crushing the lens between the instruments, crushing it again between the instruments, and then now I'm utilizing some vacuum as well as some ultrasonic energy to emulsify the lens piece. Again, I'm crushing in between. You can see the fluidics in between. I'm able to crush the lens. Whenever I'm crushing the lens, I'm not activating ultrasonic energy or vacuum. I place the chopper around that second quadrant, pulling it centered toward the phaco tip, crushing the lens between the instruments. And then once the pieces are smaller, then I activate the vacuum and ultrasonic energy. So you can see it's constant on and off and on and off. When I'm crushing it, I'm not activating ultrasonic energy, but when I'm ready to eat it, I activate the ultrasonic energy and vacuum. So it's this constant adjustment modulation between my instruments in my hand, crushing the lens pieces, and then activating with the foot pedal. I rotated the second heminucleus in front of me, I placed the chopper around the lens piece, crushing the lens in half, using some vacuum to grab that third quadrant and then getting around it with the chopper and then crushing it using successive crushing forces to crush the lens piece into smaller and smaller pieces, and then using ultrasonic energy and vacuum to emulsify the lens piece. This is the last quadrant. Use some vacuum to lift it up. Again, crushing the lens between the instruments. Using some vacuum to grab that piece. Again, crushing the lens between the instruments once again. You can see sometimes I have the lens piece cradled within the grasp of the chopper, and then I come in almost sideways, and then I crush it with a sideways chop with the phaco tip. There's the last nugget there, using just the instruments to kind of tease it up out of the bag, and then using some vacuum to position the lens piece on the tip, and then crushing it between the instruments, and then emulsifying the lens piece. Because I see that big epinuclear piece, I feel pretty confident the posterior capsule is going to be safe. Yeah, that's pretty thick epinuclear material, so that's very important. Again, gives you confidence that the posterior capsule is not going to come flying up at you when you use a vacuum. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. I'm just adjusting the sleeve there a little bit. Start sub-incisionally removing the cortical material. And I really feel like with this machine, the fluidics are so strong, in particular with removing of the cortex. It's just so easy compared to the older generation phaco handpieces and phaco machines. Switch to polish mode, polishing underneath the rhexis edge, removing any potential cortical material and lens epithelial cells. Polishing the posterior capsule as well. Again, the polymer tip is so safe. I have a lot of confidence being able to polish as much as I can. And again, polishing is so important to help reduce inflammation, reduce risk for capsule phimosis, and again, also to help you with potential lens exchange in the future. You won't have a lens that's so fibrosed in the bag. So I'm pulsing BSS into the subincisional capsule fornix, which is nice and clean, pushing some cohesive viscoelastic to fill the capsular bag. Having trouble finding my incision, finally found it. Sweeping underneath the rhexis edge on the left side and then the right side. This is a single piece acrylic lens. It's going to be injected into the capsular bag. Because the lens unfolds pretty slowly, I'm able to transition to the INA. I go in with irrigation off, activate irrigation, making sure the haptics come off the optic, getting underneath the lens, tilting it and rotating at 90 degrees clockwise, removing all the viscoelastic from within the bag. Switching to polish mode, polishing underneath the rhexis edge, removing any potential lens material there. And then switching to visco mode, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. You can see this patient has a corneal scar. It's in one quadrant away from me. And in that same area, there's a large area of posterior synechiae covering about 3 clock hours. You saw a two-handed microforceps technique peeling off the pupillary membrane. You're able to see double chop, cross chop, mechanical refracturing techniques. Again, even though there's a corneal scar, since I know where I'm placing my instruments, I'm placing the instruments around the lens piece without compromising the capsule or encountering the capsule. I'm able to crush the lens with mechanical fracturing forces, again, without utilizing ultrasonic energy or vacuum. This is very efficient, very safe, and I'm able to reduce the CDE usage doing it this way by crushing the lens over and over again into smaller and smaller bite-sized bits, and then I'm able to use vacuum and sparing amounts of ultrasonic energy to remove the lens pieces. By doing it this way, I have a lot more confidence. I feel like this is very safe, very easy to do as well, especially in these cases where you're dealing with synechiae and potential iritis. You don't really want to utilize a lot of energy in this situation. You don't want to bang up near the iris as well. So you want to keep that vacuum to a minimum if possible. And so in these cases, I feel like I have a lot of control. I'm able to disassemble the lens confidently. I'm able to get myself out of trouble whenever there's situations that arise where it's difficult to remove the lens. And I'm able to have reduced CDE, which again translates to clear corneas postoperatively. So again, this patient has a history of iritis, so I'm going to inject some subconjunctival Kenalog, and that's the end of the case. So I hope this was helpful to you, and I thank you for your attention.